Good morning, friends. So welcome to yet another session of Dr. Sahasranam's ECG quiz. Now this is the fifth in this series of ECG quiz which I have been discussing with you. Hope all of you have answered the questions properly in all the previous sessions. So today, friends, I propose to show you two 12-lead ECGs and one arrhythmia. So I'm sure you are ready with your pen and paper to get this quiz solved. Now here I would like to make one suggestion. Now before you start attempting my quiz program or these slides, it is better if you have a small printout of the hexaxial reference system. You remember, no? The hexaxial reference system which I took as a class when I discussed the Qrs Axis diagnosis, isn't it? If you have that in front of you, you know what are the axes of the various leads like AVL minus 30, lead 10, lead 260, etc. Right? Or inverted AVR plus 30, etc. If you have that in front of you and you are answering this, the calculation of the Qrs axis whenever I ask a question becomes much easy for you. So I would suggest that you have a printout of this, or you just draw a picture on a piece of paper and keep it in front of you when you are answering these questions. Thank you. Now this is the ECG of an 8-year-old child who was brought for recurrent respiratory infections since childhood. Now the questions here are, what findings do you see in the ECG? Second is what is the Qrs axis in this patient? And the third question is, what do you think is the cause of the child's illness? What caused these ECG changes? So I'll give you about 2 to 2.5 minutes for this. So you can go ahead and start answering the questions. So I think, friends, time is up. We will go on to the answers to this. The questions were again, what findings did you see in the ECG? What is the Qrs axis of this patient? And what is the cause of the child's illness? Now we'll try to answer these questions. Now first look at the limb leads, right here. If you look carefully at lead 2, the P wave in lead 2 shows a peaked appearance and is 4 millimeters in height, which I have measured. The PR interval is normal, and the P wave in V1, if you look at this, is also sharply peaked and is around 7 millimeters in height. So this indicates that there is a right atrial enlargement, isn't it? And this P wave is called the P pulmonale. Now lead 1, if you look at lead 1, this shows the equiphasic deflection in this patient. Lead 2 and lead 3 are positive. So the axis would be 0 degrees plus 90 degrees, which would be 90 degrees, isn't it? So the Qrs axis is plus 90 degrees in this patient. Now the next point is, if you look at the R wave in V1, it shows a notch in the upstroke. It's tiny, but it is not wide, and the R wave is 10 millimeters in height. It is narrow. This is due to the right ventricular hypertrophy. So this patient also has RVH. Now if you look carefully at leads V5 and V6, right, which you can see in this here, lead V5 and V6, the R waves are very tall. It is 34 millimeters in V5 here, and it is 26 millimeters in V6 respectively. So it indicates what? Left ventricular hypertrophy. So there is right ventricular hypertrophy as seen in V1, as well as left ventricular hypertrophy seen in V5 and V6. Now if you look at the mid precordial lead, especially lead V3 here, you can see tall R wave and deep S wave touching almost the upper and lower borders of the ECG paper. What is this called? This is called the Kvs-Ecg sign. We have discussed this when we discussed biventricular hypertrophy. So this patient has hypertrophy of both the ventricles, right and left. Now the question is, what is the clinical condition? Being an 8-year-old child, you would suspect a congenital heart disease, isn't it? And saying that the child had recurrent infections from childhood. So you suspect a left to right shunt in this patient. Now, which is the left to right shunt which produces biventricular hypertrophy? It is a ventricular septal defect. Now here the P pulmonale which has developed here and the right ventricular hypertrophy which has developed here tell you that the child has already developed pulmonary artery hypertension, isn't it? Or in other words, the child has developed an Eisenmenger syndrome secondary to a large ventricular septal defect with a left to right shunt, isn't it? Of course, this child had cyanosis and clubbing of the fingers and the investigations later on. Those days, this was an old ECG. Those days we didn't have echocardiography. So cardiac catheterization and other tests were done. And they confirmed the presence of a pulmonary hypertension with a large ventricular septal defect. That was inoperable at that time because the child came very late in the disease. Okay. So the findings are P pulmonale, RVH, LVH, which is biventricular hypertrophy, Kvs-Ecg sign, and Qrs axis of plus 90 degrees. The diagnosis was congenital heart disease, a ventricular septal defect with pulmonary arterial hypertension. So we'll go on to the next slide. Now this is the ECG of a 75-year-old man who came with a history of recurrent episodes of giddiness and an occasional blackout. ECG in a single strip. This is a single strip actually. From top to bottom, it is a single strip cut into 3 pieces. So all 3 panels are continuous with one another. That you have to remember. And it is lead 2 as we have shown here. Now my questions here are, what is the diagnosis of the arrhythmia in this patient? 2. What is the probable cause of this arrhythmia? Third is, what investigation you would like to do to confirm your diagnosis and to plan your treatment also. And 4th, what treatment you will offer the patient. So repeating, what is the arrhythmia? What is the cause of the arrhythmia? What investigation you would like? What most important, give me only one investigation. Important investigation you would like to do, both to confirm the diagnosis and plan your further action. And what treatment you will offer for the patient. So I'll give you a little more, about 3 minutes or a little more than that, because I know there are 4 questions to be answered. So friends, we'll go on to the discussion of this ECG. I gave you a little more time because I know that there are 4 questions. The 4 questions which I asked were: what is the diagnosis of the arrhythmia? What is the cause of the arrhythmia? What investigation you will do? And what will you do for the patient? That is the treatment. Now, this arrhythmia, what you see here, is a regular narrow QRS arrhythmia, isn't it? But it is slow. So where is it arising from? If you look carefully at the narrow QRS complexes, this arrhythmia, because of the narrow QRS, is coming from above the bifurcation of the bundle of His. Second point, are P waves seen? If you look carefully, the P waves are seen in the upper panel and the P waves are upright. And lower panel, 1, 2, 3. The first 3 beats show P waves which are positive. After that, they become negative. Not only that, the P waves are seen before the QRS complex, or they are walking into the QRS complex in the upper panel, whereas in the lower panel, the second part of the upper panel and the lower panel, the P waves are coming after the QRS complex and are inverted, isn't it? These are the findings which you see. Now, as the P wave is inverted, so where is it? This inverted P wave, where is it produced? It is going from below upwards. What are these positive P waves? They are the normal sinus P waves. Then the question is, are these sinus P waves conducting the QRS? No, because the PR interval is short, too short. And second thing is the P is going into the QRS. So there is a AV dissociation. The P and the QRS are dissociated, right? Now, what is the rate of the P wave here? If you calculate the rate of the P wave here, it comes to 40 per minute. The rate of the QRS is also 40 per minute. Both are running at almost the same rate. Now, how did you get 40? That is, the RR interval here, which I have measured already, is 37 millimeters. And so 1500 divided by 37 gives you 40 beats per minute. So that is the rate. So this is a narrow QRS rate beating at 40 per minute, not with a conducted P wave. So it is a junctional rhythm. Okay. Now we have said that in the upper panel, the P waves are produced by the sinoatrial node. Sinoatrial node itself is coming at a slow rate of 40 per minute, right? So these are not producing the QRS complexes, which you have seen. That we have said already, it is due to the junctional rhythm. Later what happened? The P wave, after this upright P waves or the sinus P wave, the next sinus P wave fails to appear. Because it fails to appear, the junctional rhythm produces a retrograde conduction upwards of the P wave, and that goes and captures the atrium. From then on, continuously, the P wave is retrogradely conducted upwards because the sinus P wave is not coming at all. Okay, I hope you got the point very clear. Now, the second question. What is the cause of this illness? That is what my second question. In an elderly person who has a sinus bradycardia, P waves are very slow. So there is a sinus bradycardia with a junctional rhythm. Junctional rhythm is also called, it is an escape rhythm, isn't it? It is protective because the sinus has failed. If the sinus fails, the patient has to have some other rhythm. So the junction has taken up the beating of the heart. The commonest diagnosis here then would be a degenerative disease of the sinoatrial node or sinus node, which is called the sick sinus syndrome. Now, this sick sinus syndrome can also be caused by other medications like beta blockers, calcium blockers, and antiarrhythmic drugs. Damage to the SA node during surgery can cause it. Inflammatory diseases, various inflammatory diseases like myocarditis can produce sick sinus. And also, of course, you have the ischemic heart disease, which can always produce a sinus bradycardia with a junctional escape rhythm. Now, my question was, what investigation you will do for this patient? You can order a simple 24 or 48-hour Holter monitoring, isn't it? A continuous Holter monitoring for 24 to 48 hours. If the patient gets any symptom of dizziness or syncope at that time, he has to make a note of it and you diagnose what is the arrhythmia which occurred at that time. They may be getting long pauses, sinus pauses or asystoles. Now you have facilities for implantable root recorders which you can implant in the pectoral region here, and they can give you the externally the impulses can be recorded using a recorder. They can be transmitted to the doctor's office if necessary, and this can be kept inside for even up to 1 or 2 years or 3 years, up to 3 years can be kept. But that may not be required in this patient. A Holter monitoring was sufficient, and this would correlate the symptoms of the arrhythmia and show if there are long period of pauses which may be causing the giddiness, syncope, etc. So the treatment of course would be a permanent pacemaker. To maintain the atrial boost, I would always recommend for this patient a dual chamber pacemaker where the atrial and the ventricle are stimulated sequentially one after the another so that the atrial boost is maintained for this patient. I hope it is clear. You can listen to this part of the slide or talk again once again. We will go on to the next slide. The sinus bradycardia, junctional rhythm with retrograde conduction, sinus node disease and sick sinus syndrome. So friends, we'll go on to our next ECG, which is that of a 53-year-old male who came with cough and dyspnea on exertion of 2 years duration. He gives a history of chest pain about 6 months ago, treated in a nearby hospital. Now the questions here are simple. What are the findings in the ECG? Second, calculate the Qrs axis in this patient. And what is the clinical diagnosis based on the ECG? What could be the cause of his dyspnea in exertion of 2 years duration? So I'll give you a 2 minute or 2.5 minutes for this. Okay. So we'll go on to the answers to this. I gave you a little more time because I know this is a little difficult. There are 3-4 questions which I had asked you. That is, what are the findings in the ECG? calculate the QRS axis of the patient, what is the clinical diagnosis based on the ECG, and what could be the cause for his dyspnea. The ECG findings are P waves and PR interval are normal here. QRS is widened, right? The QRS, if you measure, it comes to 3 millimeters in width. Now coming to the chest leads, you can find that there is a QR pattern in V1. I know it is a little faded, but you can still see QR, that R is somewhere here. It's very tall. The R wave is tall and it comes to about 20 millimeters height. Now following this, you can see a QS pattern in V2 and V3. Of course, V4 shows a small R wave here. And V5 and V6 are showing very small R waves and a significant S wave also. You can see S waves in V5 and V6. Now, what does the QR in V1 indicate? It indicates the presence of a right bundle branch block, because widening of QRS complex and a QR pattern in V1 shows a right bundle branch block. Of course, the QS pattern here confirms the presence of an old anterior wall myocardial infarction. Mind you, the patient gave a history of chest pain treated in the local hospital 6 months ago, isn't it? And so the QR in V1 is definitely due to the RBB. But here there is one point. The height of the R wave is about 20 millimeters, isn't it? What does that indicate? It indicates an RVH, right ventricular hypertrophy, is present along with the right bundle branch block. Also, this is supplemented by the presence of S waves in V5 and V6. So that confirms that there is a right ventricular hypertrophy. So the patient has a right bundle branch block with a right ventricular hypertrophy and an old anterior wall myocardial infarction. Now we'll come to the QRS axis. Now this also is not as simple as the previous one. If you look carefully, what is the QRS? You have this simple thumb rule, which I told you. Lead 1 is negative and lead 3 is positive. So according to your thumb rule, when you hold your leads like this, your lead will be showing your lead 3 shows the positivity, isn't it? So according to the thumb rule, it would be QRS axis is to the right. Okay. Now lead 2 shows a biphasic deflection with more positivity. If you invert AVR, this one, if you invert AVR in your mind, it will be less positive and more negative. So this is more positive and inverted AVR shows less positive. So actually the biphasic deflection or the equiphasic deflection comes between AVR, which is plus 30 degrees, and lead 2, which is plus 60 degrees. So between 30 and 60 it is 45. So at 45 degrees there would have been an equiphasic. This is something which you are deducing. I have discussed this in the discussion on QRS axis. So you have to add now 90 degrees to 45. To which side? To the side of right side, isn't it? So 90 plus 45 will give you 135 degrees to the right. So it is a significant, very significant right axis deviation of 135 degrees, right? Now normally when we discussed RBB, we said that the axis is not so much to the right in RBB. So when there is an additional extra shift of the axis in RBB, you will also suspect what? A right posterior fascicular block. I'm sorry, left posterior fascicular, not right. Left posterior fascicular block. Okay, so a left posterior fascicular block. Final diagnosis here will be anterior wall myocardial infarction old with a right bundle branch block and the axis showing extreme right axis. So there is a left posterior fascicular block. There is also right ventricular hypertrophy. So you have multiple findings here. Now what is the possible cause of the right ventricular hypertrophy in this patient? Because of the history, it could be a chronic obstructive pulmonary disease. In fact, this patient was a chronic smoker who had developed a myocardial infarction and he was suffering from COPD also. So chronic obstructive pulmonary disease would have been the findings, of course, were anterior wall myocardial infarction right bundle branch block, left posterior vesicular block, and right ventricular hypertrophy. So friends, I hope you found that this session was useful and challenging. I will meet you soon with yet another session on my ECG quiz program. Meanwhile, I would request you to give your comments or queries into my quiz in the comment box below, or you can email me the questions in this email address which I have given here. You can share these sessions with your friends and colleagues, and also subscribe to my channel if you have not already subscribed before. So long friends, au revoir. See you shortly within 2 or 3 days with another new episode. Thank you.